Thank you so much, Angie. And thank you, everyone, for joining me today. So, we're going to be talking all about hormone testing, different mediums that you can use, the physiology of the kind of behind the scenes version of that, and then clinical applications, which is probably the most relevant. Like, how does this apply to clinical practice and what does this mean for you? So I just want to start out by saying if you've been frustrated at trying to figure out what is the best medium to choose for hormone testing, you are definitely not alone. There's quite a bit of nuance when we ask that question, like, hey, what is the best type of testing? And so hopefully today, by the end of the presentation, you feel no matter which medium you're using, you feel a little bit more confident to say, hey, this is going to be the correct choice for the patient in front of me and for the situation in front of me. There are pros and cons really to each medium, and we'll go through that so you can make the best decision. But really, I just want to arm you with scientific explanation behind some of this that you may not actually be aware of or been exposed to. I know I was fascinated to learn all of these nuances because this isn't something we're taught in medical training typically, unless you're working with a very specific like laboratory setting. Most of us are in clinical practice and we just don't have the exposure to that. So we will elucidate all of that for you. Okay. And really, this is the bottom line. It's serum, saliva, and urine. The comparison of these testing mediums, I think, has somehow gotten controversial in the field of medicine. In my opinion, it's not really, it's kind of like fighting over apples and oranges and pears. Is there one that's better than the other? Not really. I mean, they're all amazing fruits. You may have your preference. I love them all, but I do choose them for different reasons. And one of the main takeaways today that you'll understand is that there's not a quote unquote wrong way to do this, to test hormones. But again, there are pros and cons and some nuances that I want to elucidate for you so that you're just simply aware of those and you can choose the best medium for the given situation. So I want us all to feel more comfortable by the end of the day here. I want us all to be respectful no matter what our colleagues are doing, and remain friends at the end of the day, remain professional, and still have a high degree of collegial respect no matter what medium we're using and no matter what another person is using, even if that's different than us. If you've ever wondered how Lance Armstrong won the Tour de France 7 times and never tested positive for performance-enhancing drugs, today's presentation is going to answer that for you. But just a hint here, Lance and his team of doctors knew about the nuances of tracking steroid hormones in various testing mediums and basically was able to exploit the weaknesses of the doping control system. And again, by the end of today, you're going to be a physician that would have caught Lance right away, and he wouldn't have gotten away with this 7 times over. So as a reminder here, we're talking about sex hormones. We're talking about steroid hormones today, not protein-based hormones. And all steroid hormones are made from a cholesterol backbone. So if we just remember this piece, it's going to serve us very well when we try to answer the question, hey, which type of medium should I be using to test? So like cholesterol, these steroid hormones are not soluble in water. They are hydrophobic, lipophilic, non-polar. Those are all the same kind of description there. And this is an important concept because urine and serum are aqueous substances. They are mostly watery substances. And so because these hormones, these steroid hormones are hydrophobic, when they're in these watery environments, they have to be bound to a carrier protein or they have to be conjugated, which we'll talk about a little bit when we get into the urine testing. But this simple concept is really essential when it comes to comparing the different mediums. And this is also why talking about steroid hormones is a very different conversation than talking about protein-based hormones, so something like thyroid hormone or luteinizing hormone. Very different methodology. So a little bit of history here. this is something that I was always curious about, and took me some digging to find kind of the timeline of how this all evolved. But it was really in the late 1940s and the 50s when urine hormone testing came about. This was the first type of testing that we had in our world. And then a little bit later, say like late 1960s, we had an improvement in the way that then the methodology of how we were testing in urine. So you'll see that that's that second kind of bubble there. It wasn't until the mid 1970s that serum testing, serum hormone testing really took off. And then we moved more towards that because it was a little bit easier, more considered more of the gold standard. 2000 saliva testing picks up, even though that came about actually in the early 1980s, but really didn't kind of take off until the year 2000. And then early 2000s, a little bit later, we started to lean into something called LCMS, or liquid chromatography mass spectrometry. And this is really the kind of epitome at this point in time of methodology because it's so sensitive. However, it is oftentimes, and when this started in the early 2000s, it was just so expensive and technically challenging to do that it was only being utilized in laboratory settings and research settings, so not yet in the commercial setting. That's now changed. We do have that available in commercial settings often, and it really becomes more of a conversation when you have, say, urine testing, when you're looking at the breakdown products of these hormones. So they're teeny, teeny, tiny little molecules, the breakdown of the breakdown of the breakdown of some of these unconjugated hormones. And that's when you really need something like LCMS to get an accurate test measurement. Okay, so that's kind of the timeline. We do have some institutes for interdisciplinary salivary bioscience research that emerged from Johns Hopkins in the 2010, and then 2016, University of California also had a research group start. So let's talk about serum testing first. Let's go through all of the advantages and the disadvantages. Certainly the most well-accepted mainstream marker, this is considered the gold standard. And this is due to really the time involved, the wide acceptance and the familiarity that all doctors and research institutions have with this. It's the most widely used medium in not just research settings, but also clinical practice as well, which I'm sure you can attest to. It's quite convenient. You can draw a whole host of other markers all at the same time. So that is really easy to do. It's the best place to test, certainly for more polar molecules, or like I was alluding to, those protein-based hormones, so TSH or prolactin, LH, FSH, things like that. And it does provide a snapshot of the total levels at the time of draw. So really, when we're talking about, the population as a whole or a large hospital setting, this really does have a huge advantage because of the efficiency of how we can test and getting all of that information kind of at our fingertips. Some disadvantages here. I think the main disadvantage is we're always going to be working against these binding proteins that bind the free levels of steroid hormones. So this is especially true if there's, say, an oral estrogen being utilized. We know that when estrogen is moved through the digestive system, through the liver, it increases sex hormone binding globulin, and that's going to bind even more of these free levels than might otherwise be bound. But this is mostly the problem, is that we're typically interested in knowing the free levels, but we're always working against this when we're looking at serum steroid hormones. Okay, when we're talking about cortisol, if we wanted a diurnal test to see what the pattern of cortisol is throughout our patient's day, the patient would have to go to the lab 4 times over the course of the day. Serum can be great for catching, vastly out of range Addisons or Cushing's, but it's not typically sensitive enough to catch these functional changes that most of our patients are dealing with HPA axis dysfunction. We do have issues with white coat hypertension or having a difficult blood draw. That can increase cortisol if that's what you're interested in. And that cortisol is secreted in response to ACTH, or the stress hormone. And there have been studies looking at this, that ACTH will increase within 90 seconds of that blood draw. And then cortisol will increase 4 minutes after that. So you can imagine if you do have a patient that maybe is a difficult blood draw, or for some reason you're having a hard time, or the phlebotomist is having a hard time, and that, equates to 4 minutes of time, you're going to get an abnormally increased cortisol level there that may not be reflective of the average day for your patient. Hopefully not. Now, the biggest challenge is that most of the hormones in the serum are bound to these carrier systems. It depends on the hormone, but up to at least 97, if not 98% sometimes. So they're either bound to sex hormone binding globulin, thyroid binding globulin, cortisol binding globulin, maybe albumin. I will also mention some other ones that I think are not commonly thought of later on today. And so we have to develop methods that separate this. That's the whole goal. There are what are called direct methods that can separate free from bound, but this is done in vitro in a kind of simplified laboratory setting. And what is considered to be the gold standard, like the best of the best way that we can do this, is through something called equilibrium dialysis. And this is the gold standard of the direct method. In commercial settings, we're not using direct method. It is time, it's a time suck. It's quite technical in the way that we do this, and it's expensive. And so there's no way that we can be doing this for every single patient, right? But in research settings, this is how it's done, because we say, hey, this is the gold standard. Let's compare everything else to this. And I want to mention here, because I was so fascinated to learn this, that it gains this designation as the gold standard, not because we have experimental evidence to say that this is the correct and the most accurate way, but it's because it adheres most closely to a theoretical framework called the law of mass action. And I'll talk about that a little bit more in a bit here. But that basically, just as it's a theoretical framework that was taken from the early 1800s, when we were studying kind of how solvents were moving at a certain temperature in basically a test tube, not in a live body. Okay. So I think we have to remember that the human body is so complex. There's so many different biological functions happening that to compare and to equate those two as the same thing is there's a huge gap there that we need to recognize. Okay. So equilibrium dialysis. The other one is it's actually, I think I wrote this incorrectly on this slide. It's called centrifugal ultrafiltration. So that is the other type. There is also gel separation or solvent extraction, which aren't as accurate, I would say. It's mostly that equilibrium dialysis and the centrifugal ultrafiltration that are the most common. Okay, but in commercial settings, like if you send your patient's blood to a typical laboratory, they're going to be doing an indirect method, or other words termed a calculation method, to give you the free level. Okay, so those are very distinct and separate issues. Now, if your eyes are glazing over already, I want to apologize, because I think this is kind of the nitty gritty that we have to get through to really back up and have this understanding of, okay, why does this matter, and should I care about this, and how is this going to change what I'm doing on Monday morning with my patients? Totally fair. I love how this author from 2004 stated this. He said that this type of work, meaning studying sex hormone laboratory testing, is relatively non-sexy, despite the hormone being measured, and would be viewed as pedestrian by a lot of funding agencies. There's not a lot of people looking to study this and to get, this wonderful grant to do these big studies, right? Not only is the person studying them probably down a rabbit hole, but the funding agencies are like, oh, this is boring. Like, what, why would this matter? These papers make for daunting reading because of the density of this methodological description. You probably already heard me talking, and it's just like, oh, why do I care about this? So both the measurement and the statistical analysis, but it does really matter for clinical reasons and for research audiences. The problem is it's just so painful to get through. So my goal today, and I hope I did this okay, you'll have to tell me at the end if I did. Thank you, Jean, for saying I can go as deep as I can. I've had other people say, no, don't do that. So, you know, we'll we'll attempt to go there. I hope that at the end it's fairly clear why I think this has been so fascinating. I just haven't heard other people talking about this, and so we'll talk about it today and come up for air at the end. So this is the calculation method for free hormone levels. There are different calculations that are used by various laboratories. I didn't know this. I didn't know that I could maybe reach out to a laboratory and ask them, hey, which calculation method have you chose to report all of this? So we have a few different ones here. Hands down, if you look to the research science, the people who have, gone through these dense papers and really studied this, generally all say it's the Vermeulen equation that is the most accurate out of all of these. Now, that equation came about from studying males and testosterone levels. Okay, but it was just simply applied and we use the same equation for females, for estrogen, and even children. So that is another sticky point because total testosterones in women are approximately 10-fold less than those in men. And the free testosterone concentrations are even lower, even 20-fold less than in men. And because estrogen increases sex hormone binding globulin, that binds with high affinity to sex hormone binding globulin, then the sex hormone binding globulin levels in women are highly variable, and that can actually change this calculation. And I'll show you what this calculation is here in a slide or two. So that's what it is. There, I would say if you're using Serum, it might behoove you to reach out to the laboratory of your choice and say, which equation are you using? And then just make sure you're sticking to that same laboratory that's using that same equation every time, so that if you do serial testing, you're going to be at least getting the same equation each time. Some of us, I think, have no idea about this, and we're getting different equations, which will have different outcomes. And you can see how actually potent this can be when we're changing every single value in the equation, which can happen. Okay, there's also something called the free androgen index, which is like a very simplified version of the calculation. It's just using, and you can even do this yourself if you get the sex hormone binding globulin and the total testosterone, you're basically just multiplying that by a factor and you're getting the free androgen index. So pretty simple. A lot of laboratories do use this. I think there has been consensus that using this in males, especially say on TRT, is reasonable. And I hesitate to say that because I think it's reasonable if you do serial testing at that same lab and you see consistency. Is it completely correct to begin with? I don't know. I'm going to play devil's advocate and just kind of show you some of the behind the scenes stuff on this and show you kind of why I hesitated when I learned all of this. Like, oh my gosh, what is happening here? So this is the Vermeulen calculation that was used originally on males for testosterone, and it's been adapted and just used the same equation, say, for, in this case, we're looking at free estradiol. So I know this looks like a bunch of just sporadic numbers, but really the bold section here is what the calculation is, where FE2 is free estradiol. We have albumin, sex hormone binding globulin, and total estradiol. So these are the three measurements that it highlights how accurate those have to be at the start to get an end result that is accurate. Okay. And then we also have to have what they call an association constant, or Ka. And that really it's the binding affinity. So how tightly is sex hormone binding globulin binding to estradiol and then to albumin? We have to have that calculation first, and that has to be correct. And then we'll put that into the equation. So you can see where there's all of these different various factors that really do have to be beautifully correct in the first place in order to get an end result that is making sense. So remember, I said that calculation is originally derived. It uses the law of mass action. So again, this was done in the 1800s. It focused on chemical kinetics of simplified systems in relatively dilute pH buffered aqueous solutions, meaning this was a highly controlled environment. when we're dealing with biological systems like the human body, like our patients in front of us, especially if we're involving bound particles, the assumptions based on these simplified models may not accurately describe the behavior of what's happening in our patients' bodies. So there have been some inconsistencies. When we look at direct measurement, maybe that equilibrium dialysis, and we're comparing that to free estradiol calculations in many studies, they're not matching up sometimes. And so this could be part of that, is because, I think it's a great theoretical framework, but we all know patients are quite complicated, and taking a simplified laboratory setting and then just assuming that that's actually what's happening inside the human body, you can see where there's a gap there. And then we also have this issue where sex hormone binding globulin and albumin levels, they have some challenges when we try to measure them. Okay, so usually this is done by immunoassay, which is the commercially available way to measure this. But there's standardization issues if you look from laboratory to laboratory. We even have the World Health Organization who said, hey, this is what you can use. This is the standard of what you can use. But we've actually looked over time and we see inconsistencies with that standardization. So that's going to be moving out into these laboratory settings. We also have this issue of, and I found this really interesting, that sex hormone binding globulin has antibody specificity and even glycosylation, which can form, we think, different types of sex hormone binding globulin. So that's going to add to the complexity of this calculation that we're trying to get after, this beautiful free level that we're trying to make accurate. And then we also have the issue of sex hormone binding globulin changing with thyroid hormone, estrogenic hormones, like oral contraceptive pills are going to increase sex hormone binding globulin, right? Liver disease will do this as well. And then these levels will be decreased by things like obesity, androgens, prolactin, puberty, progestins, insulin, IGF-1. I guarantee you that linear calculation we have cannot account for all of these various changes. Or just testing that sex hormone binding globulin immunoassay from the get-go, which is then going to change that calculation factor every single time we use that equation. Okay, sex hormone binding globulin is also sensitive to denaturation, and then albumin actually seems to decrease with age, and we're not taking the patient's age into account when we're doing this calculation, and so we're missing that as well. There was a nice article, I think, from Rosner in 2015. He reported a threefold difference between the highest and the lowest association constants for estradiol. How tight does that bind to sex hormone binding globulin? Twofold difference between the highest and the lowest for the estradiol albumin association constant. So again, if you have issues with that, then you're going to have wide discrepancies in that actual calculation. All of these fun issues that we're having. Sex hormone binding globulin and albumin are really they're the only binding agents that are used in that Vermeulen calculation that is so popular. But we have other studies suggesting that there's other hormone carriers, not just those two things. So red blood cell membrane, highly, highly likely that this is a huge carrier of sex hormone sex hormones, especially for transdermally applied hormones in hormone replacement therapy. And I'll talk quite a bit about that. We also see the potential of lymphatics being a carrier here, and those, of course, are not put into that equation. The authors point out too that so we're talking as a negligible variation, not even a huge thing. So say 1% difference in the binding capacity can result in the study that I'm showing here. It actually resulted in a 100% difference, or twofold difference between the reported level. So, you can just see where this compounds on itself, and it becomes, I think, a larger issue than any of us realize. There's a number of publications that find disagreement between measured and calculated values, not just of estradiol, but even free testosterone in the serum. So this is not just me saying this, although I do just have a lot of interest in this subject. So I've listed some other studies there to take a peek at. So here's the deal. If the the methods for the free calculations have potential flaws, maybe not even actual flaws, potential flaws. It does raise the question about the accuracy and reliability of the results and just the testing methodology in the first place. I would argue that methods shown to be inconsistent with serum values do not necessarily make them flawed. I think that's been a huge thing in the research where we say, oh, this didn't match up with the serum levels, therefore this one is wrong, right? But we've never stopped to say, well, hey, can we challenge this status quo and think about, is serum correct from the first place? This is like, for a doctor, I know how uncomfortable this is. For me, this was uncomfortable. It's like saying the sky isn't blue. It's a tricky subject to talk about, but we're doing it. And then the methods that are consistent with serum values may not be inherently correct. It doesn't make them automatically correct. So that's my little pin for today I'd like you to think about. And as Rosner points out, that despite all of these issues, calculation is still the most prevalent way that free estradiol is reported. With consistent calculation factors, the results between serial serum measurements can be comparable, thus giving the false impression of accuracy by the majority. Uncomfortable, again, as a clinician to think about this, but I think fascinating from just a scientific standpoint. So, we do have some challenges here. It is definitely, serum is economic, it's efficient, it's simple. It's the status quo at this point. Shifting that is going to be such an upheaval. I just don't think that that's probably ever going to happen. And there remains this potential, though, for variation and inaccuracy in this calculation validity. Even with the direct measurement, I think there's some holes there. So we have this issue even with the association constants. There's discrepancies between them. And I want to point out that this is an unsettled issue in laboratory science. We don't have an answer of how to fix this, and I won't be able to fix that here with you today. So I'm going to leave you with that discomfort. I apologize for that. But I think, again, it's still important to talk about. So I'm just summarizing here everything we've talked about. We have the issue with the binding globulins in serum. That's always what we're working against. We really want to know what that free level is. The law of mass action, which is the theoretical framework to develop these calculations, show us that these calculations you have to have a total hormone from the get-go that's totally accurate. You have to have accurate sex hormone binding globulin levels. You have to have accurate albumin. You have to have an accurate association constant. And all of those factors you can see have various issues in getting to that accuracy because we're doing this outside of the human body. We're doing this, in a calculation. Okay. Small variations there can really affect the end result. So I would say, here's the deal. Some of us we have to use serum. That's just how our, practice is set up. That's what works best for us and for our patients from a cost perspective. There's many, many different reasons for that. So I would just say, if this is you, I would just be conscientious to use the same laboratory each time so that you're comparing the same. Hopefully the lab is using the same calculation every single time and would make you aware if there was some kind of change, behind the scenes. But ideally, you would be getting that vermilion calculation. Maybe you're getting the free androgen index. You'll kind of have to find out and try to get the same, one every single time. So I wanted to start this table. I think, again, one of the most confusing things is how do you track hormone supplementation? If that's something you're doing in your practice, that's a different it's a different conversation than how do we test endogenous levels. Really, you can use any medium to test endogenous levels, like what's created by the body. But when you start getting into hormone replacement, there's some nuances there. Can you track endogenous steroids in the serum? Yes, of course. Can you track oral? Yes. with some caveats, oral delivery is creating, because it's going through the digestive tract, you're seeing a lot of conjugated metabolites. And immunoassays may not be reflective of that. When you get into using something like mass spec, it's probably more accurate. Topical, I would argue no, and I won't leave you here. I will go into a lot of detail about that when we move on today. But again, I would not recommend changing the dosing based on serum values if someone's using a topical hormone replacement. Vaginal is going to be similar to topical in the absorption. And then sublingual, we'll put a maybe here because hopefully most of this is being absorbed in a topical fashion under the tongue through the little capillaries. So in a, transdermal, if you will, fashion. But, just by the nature of sublingual, the patient will swallow some, and some patients swallow more than others. So then you're it's an in-between between topical and oral. So we've got a no and a yes equals a maybe, okay? And then pellets or intramuscular, yes, when those are inserted or subcutaneous tissue, they are delivered much like endogenous steroid production is delivered throughout the body. So you will see some in the venous circulation. You're still always dealing with those binding globulins. So I say yes, and in a very technical sense, I think still that you might have the issue of inaccuracy, but for the most part, you will see the serum level change. Yes. Okay. So here's my takeaway and some clinical pearls. If you are potentially someone that has had to use, only serum testing, and maybe you have patients on transdermal therapies, to just, let's be mindful. Maybe this is obvious, but listening to our patients and getting their experience. I think so many patients just feel like they haven't been heard and their symptoms aren't controlled and they're still not getting help and the serum levels are quote unquote fine and we don't need to do anything. So just reminding ourselves, let's always make sure we're not stuck in the black and white numbers of laboratory testing because it's an imperfect science. We get as close as we can, but it is imperfect. And so making sure we're both, listening to our patients and looking at those values is a good thing. Anytime you change an HRT or BHRT dose, the body somewhat has to recalibrate that, right? And that can be uncomfortable. So I see this a lot when patients are coming to me, they've been really overdosed with hormone replacement because maybe a physician was using a transdermal therapy and tracking in serum and, trying to get those levels to rise. So they've been overdosed, but then when we drop their dose slightly, they have hot flashes, night sweats, they have this discomfort. And so the practitioner will oftentimes think, oh, well, that's the incorrect dose. Let's bump it back up. There is this transition phase that has to happen. The hypothalamus, if there's a drop in hormone, even if it's a high level to a normal level, there has to be this kind of rebalancing effect that happens. And so we have to be careful not to interpret that right away as, oh, this is the wrong dose. My patient felt better at a super physiologic dose. Okay. Tachyphylaxis is something to think about when you have a level of hormone that you're giving and patient wants more and more and more, and you push that and you push that and push that, and maybe till the serum levels increase. And then you say, okay, great. And now the patient, after a period of time, feels like, hey, this worked right when I started it, but now, every dose we go higher, I'm just looking for that same effect and I'm not getting it. And that's tachyphylaxis, right? The hormone receptor sites are likely just maxed out, and there's probably a down regulation that happens there because the body has innate intelligence and it's trying to balance that effect. So it's going to ignore some of that excess hormone. I think this happens a lot, especially with men on TRT. They push for those higher doses every single time. Like, please, I need that symptomatic relief, but it just never comes again because of this issue of maxing out super physiologic doses. And the body's like, nope, I'm not going to listen to this anymore. You have to use what works for you and your patients, right? So that's just the world we live in. If you're in an insurance-based model and this is just what you need to do, totally fine. Just remember some of these nuances and you can work around those, the cons to utilizing whatever medium you're using. I would, this is me theorizing, so please don't take this as black and white fact, but I see so many patients given super physiologic hormone doses. And I guess I'm surprised to see that they don't have more health challenges because of those, because we have some awareness that excess hormone may be risky in certain ways. I do think that exogenous excess is very different than endogenously produced excess hormone. And so I'm still conservative. I'm still going to use a physiologic dose and not push those levels. But that, that's kind of where I've come to, because I see so many patients being treated transdermally and tracked serum, and their levels are just so high that they don't have massive problems. Not saying that can't happen and that's not going to happen, but I do think there is probably a difference between the exogenous and endogenous excess in hormones. There's a great question from the equation for standard labs like Quest. I don't know, but in preparing this, it has made me want to call and find out. So if anyone finds out, let me know what type of calculation they're using. Okay, urine, let's move on to that. Advantages here, no needles. It's very stable. It's a stable medium. It's the only way to see how the patient is breaking down or metabolizing hormones endogenously or by supplementation. Really great for home collection because you can do any day of the month, any day, any time, any place. Really especially beneficial for cortisol and capturing that luteal surge or progesterone surge in the female menstrual cycle. Okay. Some different types of urine testing. There's a liquid urine testing. You can do a 24-hour first morning collection and then a 4-point collection. There's also dried urine testing, which is usually a 4-point collection. There are some benefits to dried urine. I would say pre the movement towards LCMS or mass spec, very sensitive testing, this was more of a benefit because there was analytical sensitivity, so we could enhance the ability to detect these compounds that are in tiny, tiny, tiny small concentrations. We also have enhanced stability there. In a dried form, the cellular components aren't going to continue to metabolize or form and mess with the compounds of interest that we're trying to measure. So that's also a benefit. There are some drawbacks here. Mostly it has to deal with the restriction of water prior to collection. I don't know that many physicians are aware of this, but patients are instructed to consume less than 20 ounces of water prior to collection. Hopefully patients are reading that and following that, but that is the recommendation. That's a small amount of water, especially if your patients are trying to hydrate and be healthy in general. The sample matrix, those cards were designed for whole blood, not urine. So that actually does matter in laboratory testing. I'm going to show you some examples where that really matters with saliva testing too, and show you on a graph how much that matters. There's higher variability. So both with the sampling and the reconstitution of the sample, that introduces potential errors. Anytime you have steps that you need to do in the laboratory setting or patients need to do at home, you're going to have a higher degree of variability, and it's going to compromise that reproducibility that you're looking for. So for example, this when the dried urine comes to the laboratory, it has to be reconstituted in a liquid form in order for those measurements to be looked at. So there's an estimation of creatinine, and it's an estimation, which is an important thing to remember because that creatinine value is very important. To know the viscosity or the density of that urine, that's used in a calculation for every single marker that's reported. So you really have to have the most accurate creatinine value that you possibly can. So when we're estimating it right from the get-go, it just increases that degree of imprecision. Additional sample handling steps for patients. I don't know about you guys, but my patients do some crazy things. Like, I don't know what they're doing at home in their bathroom. I try to, give them directions but these tests can be a little bit overwhelming, I think, for patients to do at home. And they've got kids running around and who knows, teenagers spraying hairspray in the bathroom. So you do have, they have to dry those samples overnight in their bathroom. You have exposure risk to household things, potential contamination. I'm not saying that's going to happen every time, but it certainly is something to think about. There are some benefits if you're looking and comparing this to liquid urine testing. Ease of collection. There's minimal additional handling that's required by the patient. to transfer to the vial and just get it out and shipped to the lab. We have method standardization. This has been, normal in laboratory methods for a long time to do liquid urine. We have better reproducibility in this case. So less sample handling, less variability, decreased opportunity for errors. There are some drawbacks. Potentially, there is an issue of dilution effects. Now, if someone was overly hydrated and their urine was very dilute, there could be possibly some components that become undetectable or non-detectable because of such a dilute sample. And again, remember, we're looking at not just the hormones, but the breakdown products of those teeny tiny metabolites. So potentially that is an issue. Now, because we've moved to LCMS testing in most cases, I haven't actually seen this become an issue, but theoretically it could be. Okay. The need for stabilization. You do want to minimize bacterial growth with a liquid sample. So the samples do have to be acidified. There's usually a preservative that's in those tube vials where the patient will pour their urine into. And as an added measure, some laboratories will ask that the patient chill those or even freeze them overnight before they ship them out. There are some just general disadvantages to urine. It is difficult to measure what I call the frank or the parent. Really, the scientific term for this is unconjugated hormone levels. So we're talking about actual estradiol, progesterone, testosterone. It is difficult to measure those. It can be done, and we do it and we report it, but that is one downside to that. I would argue that urine testing cannot accurately assess topical or oral medications. It's not reflective of tissue uptake. It's reflective of what's leaving the body. So with topical, we have a unique transport system, and I'll go into this a little bit more, which will explain to you why, if it's applied topically, it's not going to show up in the urine or the serum in venous circulation unless there is a really high supraphysiologic dose given, where basically it's maxing out the tissue site receptor and the red blood cell membranes, and it's spilling over into those mediums. You're going to see a high metabolite level with oral medications. So that could make you think, oh, this patient's, progesterone, for instance, if they're swallowing progesterone, you're going to see a lot of that in the urine within, a few hours, depending on the speed of that person's metabolism. So this is why I wouldn't use this as my mainstay for tracking those types of hormone replacement. You can use urine to measure diurnal cortisol levels, but just remember the urinary free cortisol output reflects a pooled average of the time since the previous urine void. So usually you're getting a pooling of hours represented. Saliva is giving you an instantaneous assessment at the time of collection. Okay, so those are two a little bit different things there. All right, let's look at estrogen metabolism. So why do we care about doing urine testing? Well, it's because you can assess these different metabolism and you can see what's happening for your patient. So these are those parent or frank or unconjugated hormones that you'll find in the urine. But they break down, and this is what I find is most interesting about urine testing, is you can see the direction that these breakdown products are happening in. So for estrogen, it can go down 3 different pathways. The 2-hydroxy pathway for both estrone and estradiol is shown here. So you have 2 and 2, right? 2-hydroxy. That one is considered to be the safest estrogen pathway, seems to have the least amount of risk associated with it. 4-hydroxy seems to have the most amount of risk associated with it. So you see 4 estrone and 4 estradiol. So these have more potential to cause DNA damage. We also have 16 estrone, and there is some potential there for DNA damage. It seems to be less potent than the 4. And so this is the reason why you would look at this test to see, hey, what direction does my patient favor? And then if they're not favoring the correct way, is there anything I can do about that? And this is where you would pull something like diindolylmethane. I'm sure you've heard that as a treatment for optimizing estrogen metabolism. And that's because of studies like this that show diindolylmethane increases the 2-hydroxylation of these estrogen urinary metabolites, and it moves it towards the less estrogenic side. So wonderful. If you have a patient where it's favoring 4, you can bring in diindolylmethane and hopefully adjust that, lower their risk. So super helpful information. And a study here illustrating that there's also evidence for using estrogen metabolite testing in males. This was a study looking at estrogen metabolic pathway favoring the 2-hydroxylation over 16, showing a reduced risk of clinically evident prostate cancer, and then if they had an elevated 2 pathway, that showed a reduced prostate cancer risk. Okay. Conversely, if they showed an elevated 16 pathway, that was associated with an increased prostate cancer risk. So you can use the testing to kind of look at these silent processes that are happening that may not be totally evident looking at, at the symptomatic picture. Sometimes there's some hints there, but not always. And then we looked at phase 1 metabolism. This is phase 2. So either oxidation or methylation is going to happen here. So these were those phase 1, or they're also called the catechol estrogens. Hopefully they're moving on to phase 2, and this is accomplished by the COMT enzyme. If they don't move through methylation, they get oxidized. So if they're not moving here, they're moving off into oxidation, causing quinones or semiquinones. These are estrogen metabolites that are known to cause DNA damage. So this is going to increase risk of things, unfortunately, like cancers and a whole other types of issues as well, but that's really the one that comes up most obviously in the research. So as a summary here, whenever you're thinking about maybe using urinary metabolite testing, know that you can take this information and glean some details about estrogen metabolism. So looking at carcinogenic potential, looking at how well is this patient methylating, how well is that COMT enzyme working. You're looking at phase 1 and phase 2. You're looking also at androgen metabolism. So patients with PCOS, or maybe you're suspecting PCOS, they have symptoms that are cohesive to that metabolic syndrome. You can also look at enzyme activity. So aromatase and 5-alpha reductase are the biggies here. These ones are so problematic, and they're problematic not just in androgens, but even in some of the other areas and the other hormone neighborhoods. So you can assess and see how that's going. Cortisol metabolism is interesting. It's kind of reflective of how well is this patient metabolizing. Sometimes if that's slowed, you can be thinking about things like obesity, metabolic syndrome, inflammation, even hypothyroidism, right? Like, why is that slowed down? And then progesterone metabolism, you can look at the breakdown products. You can see allopregnenolone. You can even assess, there are some papers showing that movement towards pregnanes versus pregnines, these are metabolites of the progesterone pathway, can be related to carcinogenic potential as well. There's not as much research on that, but I think this is definitely a world that is ever developing in the research area. So keep in mind when you're using urinary metabolite testing that the parent hormone that you're seeing in the urine is not always going to be representative of circulating or active tissue levels. So I think making that assumption right off the bat is probably a bit of a mistake. It might be that this patient has high levels of estrogen at their tissue, therefore they're high in the urine. It may be that, but not always. And I think, there's a few different steps that happen before the tissue reaches the urine. So we have to take that into account. The urinary metabolite levels that you're finding in the urine may also, for that very same reason, may not be representative of circulating or active hormone tissue levels. And I think this is one of the biggest mistakes that I see as providers saying, just interpreting that straight to be, this is what is at the tissue level. It might be, but we're making a few assumptions by saying that. Urine testing is really going to have a strong potential to overestimate levels of oral supplementation because of that rapid conjugation through the liver on first pass metabolism. It's likely going to underestimate levels of topically applied hormones because these transdermal hormones do not form significant metabolites because of the way they're absorbed, and they're moving directly more to tissues rather than going through portal circulation and into venous circulation and through the digestive process. So I will talk a little bit more about that. This is our table we're adding on here. We've already talked about the serum, but for urine, it's going to be very similar to serum. Can you test endogenous levels? Yes, you will see them there. Oral, yes, with the caveat that you're going to see a high degree of those first pass metabolites. So just don't get caught up in that saying, oh, this means the levels are too high. I wouldn't use it for that interpretation purpose. Can you look at topically applied hormone levels in the urine? No, you shouldn't be seeing a whole lot of that in the urine if you're giving physiologic dosing. Vaginal is going to be very similar to topical. It's a transdermal delivery. Sublingual, again, this is a maybe for the very same reason as serum. Mostly it's transdermal, but some of that's oral. So you will see some of that there. I just wouldn't interpret that to be, oh, this is the correct dose or not. And then can you see pellets or intramuscular injection? Yes, you will see that because it's moving through the body much like endogenous production. So Dr. Zeta currently has a 4-point liquid urinary hormone metabolite profile. This is called the HUMAP. I just wanted to show you what it looks like. This is the first page of it. So you're seeing these dynamically reported metabolites. You're seeing the estrogen phase 1 moving to phase 2. How well is their methylation working? What is the degree when compared to the various pathways for estrogen, 2, 4, or 16? You're looking at the preference of cortisol to cortisone, and you can see a graph of those together. You're also studying the enzymes, so aromatase and 5-alpha reductase, some of those problematic enzymes that can create a lot of symptoms and risk for your patient. And the whole point of doing this is so that you can get an overview of their entire hormone cascade, which I've shown here. When you do this test, it will be dynamically reported. So where you see these gray boxes will be lit up, whatever level your patient has, green, red, yellow, something like that. But the point is that you can target the enzymes if you want that pattern to change. Like say this patient has too much of the 4-hydroxy pathway and not enough of the 2. You could come in here and say, hey, I want to target this enzyme. I want to decrease this enzyme number 7. I want to increase this enzyme number 4. So you would simply go to this therapeutic treatment considerations document that we created all together. And we're going to look at number 7. We're going to say, hey, let me downregulate this. What's the research-based evidence, factors that I can use to do that? So you would use the negative symbol here. For 4, you would use the positive symbol here. And really amazingly be able to change the enzyme function and change the pattern of how these hormones are breaking down and potentially change risk factors for your patients. Okay, lastly, we'll move on to saliva testing. We have a lot of advantages here. We are measuring the bioavailable unbound portion of that sex hormone. This is where it shines because it makes your life so much easier and you can get an accurate reading of this. Saliva is pretty cool because it's like a lens into the body without having to go to the tissue site and take a biopsy of what's happening at that site. You get almost like a very uninvasive way to look at that in real life from the human body, not from a calculation in a laboratory setting, assuming that, this is going to be the same as that, which it's just really not. You can use this for clinical assessment. You can monitor any route of administration of hormone replacement. Simple, convenient to collect. It's non-invasive. There's no needles involved. And really, again, we are most interested in that free level. So when the endogenous hormones are created or secreted from the ovaries, they are wrapped in those protein envelopes, sex hormone binding globulin, cortisol binding globulin, right? But really, we're only interested in what's unbound. And so this just becomes the biggest kind of advantage when we're comparing serum to saliva. It's optimal for home collection any day of the month, any time of day, any place. You can do multiple samples, especially when you're looking for diurnal cortisol levels and luteal surge testing, much like urine. It's just nice for patients in that way. And it is the most effective method to accurately, I will argue that, accurately measure topical, transvaginal, rectal, sublingual, any type of hormone replacement. Some providers will say, well, I track it in other things and I do just fine. Yeah, you are doing just fine. You're seeing those levels change. but I would argue you're giving super physiologic doses anytime you're seeing a transdermal level cause an increase in the serum or the urine. Now, whether that is as problematic as, again, endogenously produced super physiologic hormone levels, that's maybe to be argued. The research is not there yet. It's not able to tell us exactly what the risk is with, use of these hormone replacement at super physiologic levels. So saliva is allowing us to look at these bioavailable levels, whether endogenous or exogenous, and that's because saliva is actually pulled from capillary blood flow around the salivary glands, and these nonpolar molecules can freely diffuse across the capillary membrane and into the salivary tissue. And so it's just kind of like an easy way to see what is happening at the tissue level itself, because that's going to be reflective of what's happening there. So the endogenous hormones, they're attached to those protein carriers, but when it's applied topically, these hormones are attaching to the red blood cell membrane, likely in the capillary. And so either way, when that moves through the small capillaries, they're cleaved off through free diffusion. It doesn't take a carrier mechanism to get that into the tissue. So again, it's going to be very similar to what you're getting and seeing in saliva. So that's why I love that medium so much, is because I get like a real biological reading of what's happening deep inside the patient's body. Okay. Progesterone is absorbed via the skin on supplementation. It's not coated with the protein carrier, but it's carried in the blood's fatty components, like the red blood cell membrane, as I mentioned. So this transdermal progesterone absorption is quick, it's efficient, it shows up in saliva within minutes, and that shows that there's absorption happening. We have in other studies looked at serum levels after transdermal progesterone application and did not see any rise in the progesterone level. And that's led to a lot of confusion. We're thinking, oh, the progesterone topically doesn't work. It doesn't absorb. We don't know what's happening, but there's been some confusion there. Like, where the heck did it go? What we're not understanding in the beginning of those tests when those first came out was that it was going directly to the tissues. It wasn't going through venous circulation. So you just weren't going to see that in the serum testing. And this plays out in the literature. Transdermal hormones are reflected in saliva, but not other mediums. And again, this has been controversial. What practitioners have not concluded is, the hormone just wasn't absorbing. It wasn't going in. I don't know where we thought it was going, just magically disappearing into the ether. But we know now that they are being absorbed, but it's just not showing in venous blood. So this is looking at 64 milligrams of topical progesterone. Saliva change was shown within 30 minutes. We didn't see any statistical change in the serum or the urine, which matches exactly what I've said, right, about the physiologic movement of these, that you shouldn't be seeing that in the serum or the urine. And so it's not the best way to track that. You'd probably increase the dose, right, if you saw that and you were using serum or urine. Just as a reminder, again, we're talking about this cholesterol derived hormone, and it's nonpolar, it's hydrophobic, it's lipophilic. Okay, saliva is the best medium for testing cortisol, just because you can have that ease of collection multiple times throughout the day. If you want to add on a cortisol awakening response, that's a really nice way to get within 5 minutes of waking, which really isn't possible in a laboratory or phlebotomy setting. And then again, at 30 and 60 minutes, you can have a really detailed view of what's happening there with the HPA axis. Usually we're looking at 4 points over the day with the diurnal cortisol, but we're adding on those additional points to see the cortisol awakening response. And again, you're avoiding needle phobias, white coat hypertension, which can, arguably influence cortisol secretion. Okay, and remember that steroid hormones fluctuate throughout the day. And so this is an example of that. Saliva samples were taken every 10 minutes in this case. So if we were to capture just one component of that, we might be capturing a peak or a trough, and there would be quite a degree of difference there. So what our lab does is to do a pooled sample from those 4 collection tubes so that we're getting an average and we're not capturing a peak or a trough there. And that's just another way that you can gain those multiple samples so that you get a better number in the end. Urine testing can also do this, right? So if you're doing a 4-point collection, you can get those multiple samples. The limitations here is we're talking about saliva is restricted to testing steroid hormones. So we're not going to be looking for TSH or FSH within saliva. It is technically quite challenging to do. You have to have a laboratory that knows what they're doing. And, you can see here 10 to 20 times the sensitivity. One aspect that can be a little bit difficult as a clinician is if your patient is coming into contact with a topical or a sublingual hormone on their lips or their hands, that can contaminate the sample. Like they actually get a molecule into the tube, and it's going to make the levels look sky high when they're truly not. And so that part can be a little bit challenging. You just have to kind of talk your patients through that, make that make sense to them. And remember, quality control matters with all types of testing, saliva in particular. You can actually see here a graph of, they looked at testosterone levels and they compared this to just passive drool. You can see this dotted line right here. Let me show you right here. So the dotted line right in the middle. And then they used what's called an SOS swab, which was done by the company Salimetrics. You can see that that has quite a degree of precision with that passive drool. If they used a cotton swab, look how not correlating that is. It's much, much higher. And then they used a cortisol swab, something well accepted for cortisol measurements, also not super accurate. Okay. So what they learned from this is that the cotton wad was acceptable for cortisol. That was great. But when they had these plant sterols in the cotton, they were cross-reacting with some of the steroid immunoassays. And so I want to show you this just because these details really matter. And I think some of the research, if you're comparing different laboratories and depending on their quality control, can really make like all of saliva look not accurate potentially. And so there are companies out there that will have quality control and help laboratories to meet all these standards. So there have been determined to be these 7 attributes. I would ask any company that you're using if they do, like what quality controls they follow, because again, in all methods, this matters, but especially with saliva, I know a little bit more about that. So I'll show you that. But routine calibration, following these rigorous quality control assays and calculating from time to time and checking in on these numbers, that's important. They've even done studies on having laboratory personnel trained in salivary testing to run the assays. That matters because if they're not trained in what's called pipette proficiency, that can have a variance in what comes out as the answer to what is my patient's hormone level. Participating in proficiency testing programs, sample exchanges, and using the validated and recommended collection method. Remember, so not using something like a cotton swab, measuring with the correct swabs or doing passive drool, something like that. Okay, so I want to just take a few minutes here because I think, serum being the gold standard, saliva sometimes has just gotten like a bad rap, I think. And we don't know the details of it, so we just assume like it's an alternative style test. But I did want to remind everyone that at least at this point in time, it is FDA cleared for estradiol testing in IVF. I expect this to expand over time. It has standardization within the industry. There is a center of excellence in salivary testing that oversees and provides third-party testing and quality assurance to saliva labs around the world, not just in the United States, but we're talking about world cohesion here in salivary science. It's not for research use only. It is the best assay determined to be available for assessment in humans. It's not a lab-developed assay. I think that's also important. There are validations across the world, as I mentioned. Collection and storage matter, though. So that matters when you're looking at these laboratories and if you're going to get accurate results. Some of the companies pool estradiol levels, like I said, that and sometimes they don't. So that could account for variance in research discrepancies. And then variance between calculated free levels and saliva levels does not equate to salivary inaccuracy. And I'm pulling that from, remember, if we assume serum to be the gold standard, the end all be all, and then we're comparing that to saliva, I think, saying saliva is inaccurate because it doesn't match up with the free calculated serum levels is not correct. Okay, a few more slides here on tracking hormone dosage and hormone replacement dosages. So remember with salivary testing, there have been studies looking at a single application versus waiting until, say, day 22. After day 22 of a transdermal application, there does seem to be a new steady state that's reached. So if you're doing baseline testing and then you're following that up, I would wait at least 22 days, bare minimum, to see what that new steady state is. And then showing here the difference between looking at 20 milligrams. This is 20 milligrams of transdermal progesterone. We're seeing this in saliva within minutes. Serum levels don't increase too much. So again, if you're a serum tester, just don't expect there to be this massive rise. And I think you'll be serving your patients well. You won't be super physiologically dosing them and trying to get that serum level to change. Sometimes I will utilize a couple slides to show my patients, how this is working, because they're usually curious. Like, if I apply this transdermally, I don't understand what's happening here. So remember that these transdermal hormones are using the red blood cell membrane as basically like a little taxi service. So this is not just me saying this. The Red Cross looked at red blood cell membrane uptake to progesterone, but also corticosteroid and cortisol. All hormones, because they're all nonpolar, remember, had an affinity for red blood cell membrane. That makes sense. But progesterone showed to have a much greater affinity for the red blood cells, 8 times greater than the cortisol. So that makes sense. Remember, progesterone is first on the list right after cortisol. It's much more hydrophobic, lipophilic, nonpolar. It's going to want to grab onto that red blood cell and hitch a ride with much stronger degree than, say, cortisol, because cortisol is much further on that pathway down. So it's a little bit more polar. It's still nonpolar, but a little less. I don't feel comfortable in an aqueous substance than progesterone. Okay, so they were saying, hey, this is an indirect support that the red blood cell is a carrier medium for topically applied progesterone. Okay, this is another study showing that same thing, just concluding the red blood cell functions as a carrier of the sex hormones, similar to that of albumin. But remember, this is not at all involved in the Vermeulen calculation. So interesting there. And, think about this. You're going epidermis, dermis, hypodermis. This is where the patient's applying it. It's getting right down into these little capillaries. And then these capillaries are moving this all to the tissue where it's going to be passed to that tissue via free diffusion. So another aspect of why serum testing is maybe not the best to track transdermal hormones, and that's because of the way that serum is routinely handled. When the blood is drawn from a patient who's applied the transdermal hormone, we understand that a large portion of that is going to be attached to the red blood cell membrane. But to separate the serum, the blood is allowed to clot and then it's spun down. The red blood cells are discarded along with that transdermal hormone attached to the membrane. So again, we're applying progesterone. We're not seeing the serum level rise. We're thinking, where did that go? Like, everyone's looking around for this missing progesterone. Oh, it's in the trash can with the red blood cells. Okay. Another reason why transdermal hormones don't show up in serum is this steroid hormone physiology. So steroid hormones are lipid soluble. They're going to freely diffuse across the cell membrane. They're going to associate with the intracytoplasmic receptors. That receptor hormone complex then enters the nucleus and attaches to the genome. The genome is then activated to produce messenger RNA. That goes to the cytoplasm and is translated into enzymes, which then alters metabolism. Phew. But that initial receptor hormone complex is then broken down within the cell and the cellular organelles. So you never actually see that again in its free unconjugated form. So again, this is part of the answer to where did that progesterone go? Another theory is that the lymphatic system is serving as a delivery method for the sex hormones, very likely because the lymphatics track the vascular system throughout the body, and lymphatic fluid is highly nonpolar and thus a very compatible medium for these steroid hormones. Now, to summarize, these transdermal hormones are free. They're largely bound or not bound. Transdermal hormones are not bound to these protein carriers, but they do have bonds with the red blood cells. But they are fairly weak. They are quickly transferred into the cells via free diffusion. The red blood cells are discarded when serum's testing. They're spun down and discarded. Hormones are broken down within the cell by the cellular organelles, and you never see those again. And then we also have potentially this lymphatic system. So that is the answer to why serum is not the best method to track transdermal, and why if you do see an increase in the levels, it's likely due to supraphysiologic dosing. Okay, so we've already talked about serum and urine. Now we're just adding saliva. The quick answer here is that you can track all of these in there accurately. Okay, the one caveat here is sublingual. This one can be a little bit tricky because you're using the same medium to deliver the hormone as you are to test the hormone. So if the patient has maybe residual hormone in their mouth, if they didn't wait long enough, if they didn't swish their mouth around with water, something like that, they're testing too soon after that sublingual delivery, you may see a contamination level, meaning there was a molecule of that hormone that got into the tube and it's going to look exponentially high when truly that's not their body level. I haven't had too much of an issue with this as long as I talk through patients with it, so that they know why this is important to follow the instructions. I did have one patient that she was using a sublingual troche, and she had like braces or dental implants of some sort, and we just kept getting contaminated levels, at that. And I think that somehow it was getting caught in like the metal of all the metal that she had in her mouth, and so that was the only time I've just consistently had an issue with any single patient. Okay, nuances of getting accurate results. And I just wanted to show you this is what the test looks like in salivary reporting. So you have cortisol here with the graph, and then you have the sex hormones here. Estradiol, progesterone, the ratio between the two. You also have testosterone and DHEA. You do want your patients to follow correct, what we call dosage intervals. So it's really common sometimes that patients just overlook this. And the problem with this is that you're going to get results back that aren't going to be quite what you want, and you're going to be having to do some guessing. So if they're using a topical, the bottom line of these dosage intervals, let me just kind of back up, is that we're trying to capture the average level of their tissue hormone level. We don't want them to collect their saliva right after they apply a topical or right after they use a sublingual, right? And so that's what you're trying to assess here. For some of these like injections or cutaneous pellets or even the patch, you're just trying to do, like if they do the pellets every 6 months, capture them at 3 months, right? Like it's common sense, but I think sometimes gets overlooked. For cycling women, certainly have them attempt to capture that luteal phase, and you'll get that progesterone level. The reference range is based on that luteal phase surge. So that's what you want to do. Okay, putting it all back together, all mediums you can use for baseline testing, but if you're trying to track supplementation levels, especially if they're transdermal, I would really caution you to pick the medium that's going to give you the best information clinically. If you need to stick with serum or you need to use urine, I would just be cautious not to be changing the dose based on those levels, but you're really looking in serum, hey, did I accidentally overdose my patients, right? Maybe you could use it for that purpose. In urine, you're looking at the pattern and the direction of breakdown, not is this level too high or too low. Okay, so I think that's going to be the best use of all of those mediums, no matter what your situation is. Just a couple side notes here. Patients on oral contraceptive pills, sometimes we get asked, is it worth testing hormones? Long story short, no, because I think you're going to, what the levels are going to be before you even test them. You're going to have suppressed basically anovulation, which is going to result in low progesterone, maybe low estrogen, maybe even low testosterone. So I think some patients are really data driven and they want to see these numbers, and that would be a relatively good reason to do it. But I think clinically, you're going to get levels that you probably could have guessed from the starting point. And then two, what are you going to be able to do with that unless the patient is moving to some different form or moving away from contraceptive pills? So I hope that helps. This is just an example of serum and saliva side-by-side testing and how it can look so different. So this was a 37-year-old female with a total hysterectomy. We tested in serum and saliva on the same day. She had recently used oral DHEA and topical progesterone. And you can see that reflected in the saliva results, but the serum levels look pretty, like, doesn't look like she's supplementing, right? So what will I say about this? So oral DHEA, 25 milligrams for a female is a pretty high dose. So I'm not surprised to see that elevation with the DHEA. After some inquiry, she let me know that she had a husband at home that was using a topical transdermal testosterone. So I think this is why her testosterone level is so high, as she's being exposed to that. That's likely aromatizing and turning into this excess estradiol, right? Because she's not supplementing with estradiol. So after a total hysterectomy and the removal of her ovaries, she shouldn't have that much estrogen. So that's coming from the testosterone. Some of this DHEA might also be pushing to the testosterone. And then her progesterone is interesting here. It looks quite elevated. She's only using 20 milligrams topically. So when I spoke to her, I realized she was actually applying this over fatty tissue. So remember, progesterone is almost pure fat. You're applying that on adipose tissue. It's going to kind of stick right there and it's going to pool and then be released at inconsistent amounts. So I would advise her to move to more of a thin skin area. Inner forearms is great, backs of the knees, tops of the feet. You're going to get a lot more stable movement through the body, and that's going to be reflected in the saliva levels. Okay, and so this is why side by side, these are going to look very different. You're looking at the biological lens into the body with saliva and serum. You're not looking at that. You're looking at the bound portion. The transdermals aren't going to be reflected there, the transdermal hormones. And then you have these calculation factors that are all at play, especially for women with sex hormone binding globulin. Okay, so this is just another kind of discussion of that same conversation that we've had. So again, Lance Armstrong, let's go back to that. Lance and his team knew about these nuances of tracking steroid hormones and were basically able to exploit the weaknesses of this anti-doping control system. So what was he actually doing? Well, he and his teammates were using testosterone sublingually in an olive oil suspension. So they were dribbling those under their tongues, knowing that that was not going to be reflective in serum or urine testing, but they were still going to get the physiologic benefits and the athletic benefits of that. And so basically he was able to trick the anti-doping testing system. Studies have been done now that promote saliva testing as a better control or a better screen for doping. And this was because we were looking at studies like this, where they used 50 milligrams of a gel testosterone topically, and they also compared that to a testosterone patch. So serum and urine did not approach or exceed the critical thresholds to say this person was, using testosterone, but we did see significant elevations in saliva. So this was assumed, at least at this report, to be a more diagnostic marker for transdermal testosterone. I still think there's been some stagnation in the movement and acceptance of that, but there it is. I guess they can take it or leave it. So saliva hormones plus urinary metabolite testing, I think this would be, in my mind, the most ideal approach if you're looking at a totally holistic approach. Do you have enough hormone, or what's the hormone level at the tissue site? And then how is that being broken down and excreted? And that is, both of those together, I think would be the most powerful approach. And again, we've had an evolution of testing over the years. I do want to impart with you that this is not a perfect science, but hopefully you got to see some of the behind the scenes stuff, the nitty gritty, so that it's not just about opinion or what I like to use or what my colleague uses, but, using some scientific approach to say, hey, this is what I'm going to use. This is what I feel comfortable with. And again, no matter what you're using, there's no right or wrong. You just have to be knowledgeable about those pros and cons so that you can work around them. And get the best approach for your patient. So I hope that we are all still friends after this if I've rocked the boat. And, I know it's an uncomfortable conversation, but I highly respect, any colleague of mine that's using any medium. I think there are, several different ways to heal patients. There's not just one way. And so I've shared with you, some science-based reasons and kind of my opinions on this. So take that for what it's worth. And thank you all so much for being here with me. I know I've gone over on time, so I'll hand it over to Angie for questions if we have just a few minutes here.